just waiting for the doctor to get out of our presence. The transcript will reflect the doctor's out of our presence at this time.
At this time, Your Honor, I would like to continue direct examination. For the record, when we had a colloquy about the scope of the doctor's opinion, I had focused on the deposition, completely forgot about his report, which is Exhibit 2005-1 through 32, something like that? 21. And in that, there is not a life care plan, but all of his recommendations to a reasonable medical probability of the care and treatment for Maya Kowalski based on her symptoms and his diagnosis. If you go to the next page, please. 19, or 20. And so there he goes on. Also demonstrated positive results of physical therapy. Treatment with Dr. Hannah specializes. Basis for diagnosis, bunch of is incorrect. She does not meet the criteria. I don't need that, but from that point up, and then the page before.
Mr. Anderson, I looked at it. Let me hear from Mr. Shapiro.
Yes, sir.
I guess I don't know what they're intending to do if Mr. Anderson is supposed to continue to correct that objection. The basis for the, just to be clear, this is a plan that he had for Maya after one visit in January 22nd, 2017. If the question to him is simply, did you have a plan for Maya's care, you can walk through it, but that's different than saying, as a result of the mistreatment that you allege at All Children's Hospital, do you believe within a reasonable degree of medical probability she has these future problems? That was the basis of my objection because, again, in his deposition, he, I believe, clearly disavowed any future care opinions because he hadn't seen her. But I don't object if he just wants to continue his direct and ask him about what his plan for the patient was on that day based on his exam.
Well, my recollection of the questions that were asked that we had the sidebar conversations on, or multiple sidebar conversations on, and my sustaining your objections, the concept was that it was an undisclosed opinion, that neither in his report nor in the deposition was there discussion of future, whether it was care and treatment or a future opinion. But this report suggests that he did, in fact, have opinions about future care. And so at this point, I'm going to reverse my rulings, and I will allow the questions that Mr. Anderson had previously asked, to which I sustained. And the plaintiff can continue in direct when we are in front of the jury.
Thank you, Your Honor.
Do you mind if I just get a quick point of clarification, respectfully, Your Honor? And I don't know if plaintiff intends to do this. Does this court find that merely because Dr. Chopra had a plan on this date for several things that he wanted and that his patient to undergo, that would open the door for him to then talk about life care plans in the future as a result of negligence, or just merely that he can discuss what his plan is?
What I was just seeing on the screen was talking about future items. So, certainly I don't know what the doctor is going to say about future items. If it's beyond this, maybe that's going to be an issue. Yeah. But it's clear that he had a forward-looking report that was presumably available to the defense. And as such, I think it's fair game at this point. And that was the basis of my objection, was it was undisclosed, but it seems like it was, at least in part, if not in totally, available to the defense, and understood that that's what this doctor was going to be saying.
And just a last point of clarification, respectfully, the objection the defense is making is any testimony about future care related to future damages, as opposed to, and I don't have an objection to him talking about in his report his future plan of care for the patient. I think those are two different separate categories. Mr. Anderson may not be going back there, but I will make the contemporaneous objection.
I think you need to make the contemporaneous objection. And it may be that it is beyond his deposition and his report, but I think I need to actually hear the specific question at that particular point in time and the specific objection. Are there any other issues we need to address?
Your Honor, we had done a request for judicial notice, which the court granted on trial exhibit 23021 and 2301.
What is 23?
And those are, I've got copies real quick.
Can you just put it up so I know what you're talking about?
Put it up. My intention, these are House resolutions regarding reflex sympathetic dystrophy month, and there was one in 2004.
What are you trying to do with a legislative resolution?
I am asking the witness to identify this and asking whether this is further evidence that the doctors at Johns Hopkins should have been aware of the problem of misdiagnosing exactly what they were diagnosing.
I'm unclear. You're asking a doctor from Rhode Island to comment on a resolution by the Florida House of Representatives?
Well, he is licensed in Florida as well, and it's a relatively minor point, but I think it is.
Has he been in the Florida legislature?
Not that I'm not aware of.
My recollection when I handled this before was I'll take judicial notice of it, but as a matter of evidentiary fact, that me taking judicial notice does not make it an evidentiary fact. I think is how I ruled, I don't know, 2 or 3 months ago.
I agree with that. I think that's what you said.
And I don't see this witness being able to talk to us about what the Florida House of Representatives has done.
I'll save it for cross or something else and I'll bring it up again.
Anything else before we bring in the doctor?
Not from the plaintiff.
Not from the defense lawyer.
Let's go get Dr. Chopra, please. Okay, welcome back, Doctor. Just to let you know, when we bring the jury back in, since we've had this break, I'm going to remind you that you're under oath. I'm going to do that in front of the jury.
Sure.
Okay, just to let you know, I'm going to do that. Let's bring in the jury.
Yes, sir. Jurors entering.
Hey, everyone, please be seated. Okay, members of the jury, I want to confirm while you were away, you did not discuss this case amongst yourselves, you did not do any investigation, and you received no information. Is that correct?
Yes.
I also want to confirm that and ensure that no one approached you about this case since we last were together. Is that correct?
Correct.
And that you have not seen any media coverage about this case since the last time we were together. Is that correct?
Correct.
Thank you very much. Mr. Anderson, you may continue your questioning, sir.
I'm back.
I know. Sticky too.
Before we broke, there was a series of questions concerning Maya's future care. And I'm allowed now to ask you about them, and I want to reference you to your report of January 22nd, 2017. And with the court's permission, I have it published here, previously discussed it. Can you go through this. You don't have to dwell on every one of them, but I want you to name off for the jury here the various treatments and the reason why they are reasonably medically necessary for Maya, given her aggravation from CRPS.
Same objection, Your Honor.
So, one of the things about treating CRPS is that I do is I know the definition is everything else has been ruled out. So the patient has severe excruciating pain and everything else has been ruled out by definition. That's the definition of CRPS. But I still look for a cause. Maybe there is something somebody missed, or there is something that I can find, and that would be obviously magical, because then if you know what's broken, we can fix it. So in her case, I looked for a condition called Ehlers-Danlos syndrome, or in brief, EDS. It's a kind of a benign condition where your joints are loose, you're hypermobile, and she had some features of that. Now, I wasn't sure about it because at that time, this was back then, there were no guidelines on how to diagnose this condition. It was actually in 2017, later on, that the guidelines came out on how to diagnose it. So I just put that there, that later on in the future in her life, she might ever want to explore that, she can do that.
Next one.
The next one was, I said that she meets the criteria for complex regional pain syndrome.
And then let's go to 3, as I think we've covered that.
So in number 3, I talked about a condition called tethered cord syndrome, and this is actually a condition common in children, and it is common in patients with Ehlers-Danlos syndrome. And in this case, what happens is that these patients have their spinal cord is not hanging loose in their spine; it's tethered to the bottom of their spine, and it's a congenital condition, and oftentimes these patients can present with pain in both their legs. And it's a neurological condition, and it is diagnosed by a neurosurgeon. I also put that in there because maybe she has it, maybe we need to do a further workup, we don't know.
Okay. Can we go to the next one then? 4.
Are we going to magnify it?
Let's see. 1, 4. I don't need to cover
Okay.
that one. I was really interested in the CRPS treatment on the next page. Okay. Now, beginning in number 5, if you could go down and let me ask you the question. From 5 down through, I think then there's more on the next page. But these from 5 on down, are these reasonable and necessary medical condition treatments for Maya Kowalski based on the aggravation of her CRPS to a reasonable medical probability?
Yes, these are reasonably necessary, absolutely.
So let's give the jury an idea here of, we've talked about things that she can look into in case, but let's talk about what you think she should be doing, or the treatment she should have.
Based on my
Your report, which is in
so
evidence.
on number 5, I put in there, recommend physical therapy for upper body strengthening exercises. So here's the thing: when she got her initial ketamine at Dr. Kirkpatrick's office, her upper body pain actually improved. The pain in her arms improved, but not the pain in the legs. And so, she was. When people use a walker, they need upper body strength because that's what they're supporting themselves on. They need to have stronger arms, stronger upper body, And so I said, all right, let's strengthen what we can strengthen, and at least so she can hold the walker and walk. So that's what I said.
And how much, as she continues in life, should she reasonably expect to attend or go to a reasonable medical probability in order to minimize the effects of the aggravated CRPS?
Well, to minimize she has to completely avoid aggravating her CRPS.
Let's assume in life there is aggravations now and again. How is the physical therapy? Should it be periodic, or should she continue to attend physical therapy throughout her life, so long as she has the symptoms to a reasonable medical probability?
I need to clarify that.
Sure.
I actually said to hold off physical therapy for her legs.
Right.
Because you cannot do physical therapy on someone who has excruciating pain in their legs.
Right.
Okay, that's it.
So
for now, just strengthen the upper body, control the rest of her pain in her legs, which had been aggravated by her whole episode at the ACH, and then work on the legs.
Okay. As she has, and to a reasonable medical probability, is Maya going to have relapses from time to time of varying degrees and types?
Yes, she is. Okay, let's talk about the relapses for a second. This
Sure.
is not a joke. We're not talking about a relapse of a little headache. We are talking about severe. She lives at a baseline pain that you and I cannot even comprehend. Okay, that's baseline pain. Her brain has now changed enough that she is okay with that pain. When she has an exacerbation, it's horrible.
And are you aware, or has it come to your attention, that she has in fact had a relapse in November of 2020 that put her in the hospital?
Yes, I know that she did, and I don't know what happened. It may have been some sort of a stress. I know she didn't have an accident or a physical fall, but it could have been some stressful event that could have triggered that.
And her already having had a relapse some, 2.5 years, 3 years after getting out of Johns Hopkins, does that have an effect on your opinion that she may have more and longer and more aggravated relapses through her life?
Same objection.
You can answer.
It's the same, it's the same analogy I gave you. If you have a wound on your arm and before it heals, you whack it and it breaks down, the skin breaks down again and the wound becomes worse again. And if you keep continuing doing that, one day it's never going to heal. One day you're going to be left with a really terrible open wound on your hand. And that's the same thing with this. If you keep aggravating her CRPS, her brain is finally going to alter itself. If it hasn't done it now, it is finally going to alter itself. That is that her CRPS will never ever go away. It never goes away. It gets what we use the word remission, where it kind of comes down a little bit, enough that they can function.
And I believe you testified to this before, but just to tie it in, do you have an opinion based upon your background, training, and experience, and to a reasonable medical probability, if whether the timing and the intensity of what she experienced at Johns Hopkins over those 3.5 months aggravated that CRPS so as to cause her extra injury and damage?
Same objection.
Overruled. You can answer.
So, I need to give you the bigger picture on this.
Okay, go ahead. I just wanted to, yes, you do have an opinion or no?
You need to add $2 there. So, I'm going to make money today. So here we are, So we have a 10-year-old girl, and she's got CRPS in her legs. Okay, but her mom's frantically running around all over the country, from Chicago to Tampa, looking for treatment for her. Okay, she finally finds Dr. Kirkpatrick. He does ketamine on her. It helps her partially. It helps her arms. Okay, we got a little win there. But then he says, look, you need much more than what I can give you. So you need to go to Mexico and see Dr. Cantu, who's going to give you a ton of ketamine. And she does. And she comes back, and she does well. Mm-hmm. And in fact, she does so well that Dr. Who's the doctor from?
Hannah or?
No, there's a doctor
Cantu?
from Johns Hopkins, a pulmonologist.
Oh, Kreisman.
Kreisman.
Dr. Kreisman.
Dr. Kreisman and her pediatrician said, this is not the same girl. This is a different girl. Her skin lesions were gone. She was a whole different girl. They both commented on that. And then, obviously, you can't afford treatment in Mexico that long. It's expensive. So she did the next best thing, was to go to Dr. Hannah, who tends to use higher doses. And so it was some sort of an agreement that she made. And she started to do ketamine with Dr. Hannah at somewhat higher doses, and she was doing great. There are videos of her swimming, running around, playing, doing great with physical therapy after Dr. Hannah's treatment. So you can see the progression, that from a lower dose with Dr. Kirkpatrick to a higher dose to Dr. Cantu, and then to Dr. Hannah, she is starting to make progress. Now she has this abdominal pain, goes to Johns Hopkins, and then everything goes down the drain. They don't believe her, they don't treat her stomach pain, they don't take care of her CRPS, they don't even, and she's been there dozens of times before, and now they treat her like they've never seen her before, they don't believe her, they stop all her treatments. And not only that, they mistreat her by keep touching her, keep handling her, and her CRPS flares up back to where it was.
So is that a yes? Johns Hopkins did aggravate her CRPS so as to cause her more damage and injury in the future?
Yes, very much.
And so let's continue down here. You've had, exercise and joint protection. I think you've talked about, avoid desensitization. Go down. Avoid desensitization exercises. What's that about?
So one of the theories in CRPS is that, all right, if because your arm is so sensitive. I'm just taking the arm. If your arm is so sensitive and if you have CRPS there and touching it makes it painful, we are going to touch it even more. We'll take a rough towel or a sponge or something like that and rub it even more so that your brain gets used to it. Okay, now that philosophy is actually counterproductive, because do you remember how I said this morning that a barrage of pain signals, if I took a pen and I stuck it in my finger again and again, there would be a barrage of pain signals to my brain. And then the brain then alters itself. And it now takes over the pain. And this is what will happen when you do so-called desensitization exercises. If I take a rough towel and I start rubbing it on the area of CRPS, you are sending even more signals up there. There is zero literature. I am not kidding you. There is zero literature on the benefits of desensitization. I have searched it everywhere. I've asked people who do this. I said, where did you learn this from? Where is it? No one knows. So,
Doctor, why don't we wait for the next question and then you can answer?
You owe me $1 back.
oh, sorry.
No. The question then is, can you describe for the jury then with more specificity, is she going to have more of these relapses than she would have had she not been interrupted in her first round of care?
Yes.
Will they be more aggravated when she has them? That means more painful, more debilitating. And third, will they be in terms of length longer? So the three, again, are she's going to have more number.
How about one question at a time?
Yes, sir. You get my question?
Yes, to answer your question, yes, she'll have more frequent incidences of CRPS because the treatment that was initially working for her was interrupted.
And will those episodes be longer in length than they would have been, or will have any effect on that?
That's a slightly difficult question to answer.
Fair enough.
Some will be longer and some may not be that long.
But can you tell us when she does have them, are they going to be more intense than they would have been had she completed the therapies that were in place?
Yes, every exacerbation she's going to have is going to be a lot more intense.
So she's going to have a lot more and more intense, but there's no way to tell the length of them.
Sustained
It's just a summation. Okay. Now, we haven't finished this. Doctor, I don't want to take a whole lot of time because it's in the report, which is in evidence, and so you can read it. They can read it for themselves. But generally speaking, can you tell me? Can you tell us? I'm going to stick a step ahead here to number 10, gastroenterology, and why that's important.
So when I talked to her, and I went through every system, and when I got to the stomach, and I asked her, "Do you get bloating when you eat?" And she said, "Yes, absolutely, I do get bloating when I eat small amounts of food." And remember, she had already been to Johns Hopkins twice. I think, as long as I remember, it was twice for belly pain. And what happens as a complication of CRPS is the nervous system that controls the movement of your intestines. So your intestines move like a toothpaste, okay? So when you eat food, it moves along like a toothpaste. And that is controlled by a nervous system called the sympathetic nervous system. And that is affected in CRPS. And that was the reason her food was not moving, and obviously it was collecting, and she was starting to have all this abdominal pain, belly pain, and she was getting malnutrition because of it.
All right. Then is there a number 12 there, or have we reached the end? It says under 11A, it was minimized trauma. I think you've covered that. And then we go on the next page to continue on to the top, please. I think there's more. Go up. Here. Vitamin C exercise program, trial of graded motor imagery. What is that?
So there was a research that came out of Australia. It's actually accepted research modality for treatment of CRPS.
Sustain that objection.
What was the objection?
Bolstering.
Oh, okay. Just tell us what graded motor imagery is, the basics.
It's in 3 parts, and the 3 parts I mentioned over there. It's a kind of an exercise you can do at home for people who have CRPS in one limb.
And then you said an echocardiogram. Is that periodic under number 12?
That's if she has Ehlers-Danlos syndrome, then an echocardiogram is a standard practice.
All right. And then, okay, positive results of physical therapy. So should she keep up physical therapy throughout her life as she's done?
Provided her pain is controlled.
Right. What about medications? Do you have an opinion based upon your background, training, experience, or reasonable medical probability if from time to time she would benefit from medication?
That's a difficult question to answer because her mother had tried a lot of medications, but that was a different time, and so we don't know if she can try them again.
Okay.
But she will need to try different medicines.
And with the based on the assumption that the relapse occurred some 2.5 years after she got out of Johns Hopkins, do you have an opinion to a reasonable medical probability that the opinions you have offered here are equally applicable for this jury today?
Objection, Your Honor.
Can you rephrase that?
That was a very good question. To a reasonable medical probability, is your report here in 2017 applicable today, these different treatments and future medical care?
Yes.
So, just a couple last questions. I think the jury will hear at some point about intrathecal pumps and Beata Kowalski's request, or just asking about it in theory. But what is an intrathecal pump, and is this some boogeyman that we should be afraid of?
Object to the compound.
All right.
Why don't we just go with
Yeah,
What
no
is the pump?
boogeyman, sorry. Intrathecal pump simply means a pump in the spine. So the principle is actually amazing. And I'll give you an example. If a person needs, say, 10 milligram, needs morphine, 10 milligram pill for their pain by mouth, 10 milligrams by mouth. If you give the same morphine into their spine, they'll only need 1 milligram, which means they need lower doses. It is far more effective because you're hitting the pain at the source, and you're also not seeing any side effects. So intrathecal is in straight language, it means spinal pump.
And from your experience with mothers and fathers of children with this extreme pain, do you find it in any way unusual or odd that she would question whether the intrathecal pump would be appropriate for Maya?
Yes, it is an appropriate request. I thought it was an amazing request that she made it because she's trying to decrease the dose of drugs that Maya is getting.
All right. And finally, is ketamine FDA approved for children?
Yes, it's used all the time for children.
And is it now FDA approved as what's known as an orphan drug?
Yes, it is.
And what is an orphan drug?
So actually the sentence should be, is it approved as an orphan drug for CRPS?
For our CRPS, my apologies.
Yes. And so, there are some diseases that, like the FDA has these rules, okay? Like they might say, somebody with migraines, we need, 1 million patients. We need you to test this drug on 1 million
Objection
patients.
that you're saying on the FDA rules.
Well, I'm just trying to explain.
You can answer that one.
You can answer.
But in some diseases that are not that common, they can't get 1 million patients with CRPS. So the FDA says, all right, we let you do it with 400 patients. And that's called an orphan drug use. So they kind of make it, they're not all diseases are that common. And some diseases that are not common, they put them down as orphan drug use.
Is that because of the expense of doing a full trials?
No, it's because they can't find that many people.
Okay. And I have to ask you one last question on liability here. And do you have an opinion based upon your background, training, and experience into a reasonable medical probability from everything you've seen here, whether the doctors comprising the Johns Hopkins pain management team, that is Laura Vos, Richard Elliott, Amish Patel, and nurse Ashley Sumner, breached a duty of reasonable care by deviating from the accepted standard of care insofar as the care and treatment of Maya Kowalski?
Yes.
Overruled. The answer stands.
And can you tell us to a reasonable degree of medical probability based upon your background, training, and experience whether that was a cause of this aggravation and this future we now know about for Maya?
Can you explain that a little bit more?
Sure. I want to know whether when you answered about they breached a duty of reasonable care, was that breach a cause of the damage and injury to Maya?
Yes, it was.
And is that to a reasonable medical probability?
Yes.
Your witness?
Mr. Shapiro.
Good afternoon.
Good afternoon.
Were you aware that Beata Kowalski chose you?
No, I had no idea.
First time you're learning about that today?
This is the first time I'm hearing this.
Okay. You're not an emergency physician, correct?
No,
You're not board certified in pediatric anesthesiology either.
no,
You, in terms of hospital privileges, you haven't had any in more than 20 years, right?
I chose not to.
Okay. You don't treat patients in hospitals.
I don't have the time to go to hospital.
Okay. In terms of your fees to be here, what are you charging?
Sorry, could you?
What do you charge to be here?
Oh, so far they've been kind enough to pay for my hotel. The rest I have no idea.
Okay. You haven't sent a bill to Mr. Anderson yet for your time?
No, I haven't.
Okay. Do you know what it will be, or you haven't tallied it?
I
up?
have no idea. My office handles that. I don't handle that.
Okay. I know you don't know the amount, but just so it's clear, Mr. Anderson, his office is paying you to be here today and for your review. Is that fair?
They're paying for my time.
Okay. Let me ask you about ketamine. You told the jury a moment ago about FDA approval. Back when Maya was getting ketamine in 2017, ketamine was not approved by the FDA for CRPS. True?
Well, yes,
That's true.
that's true.
Okay. I want to talk to you a little bit about your statement that Maya was improving before she went to All Children's in October of 2017. You base that on your review of Dr. Hana's records, right?
Actually, I base that not just on his records, but also on videos.
Okay. Well, let me see if I can narrow down a time frame here. Clay, will you put up what's in evidence as Joint Exhibit 1040-206? And you can enlarge this. I will represent to you, we can go to, this is a signed letter from Dr. Hana dated September 25th, 2016. Do you see that?
Yes.
I'll represent to you that this was written by Dr. Hana to the school district to explain homebound status. And I'm going to ask you about some of the statements in here to see if this is consistent with what you're telling the jury in terms of how Maya was actually doing before she went to my client's hospital. At the top it says, Maya suffers from horrific disease, RSD, CRPS. Do you see that?
Yes.
Your testimony to this jury is before Maya ever went to my client's hospital, she had debilitating CRPS. That's what you believe, correct?
Yes.
And as a result of her debilitating, horrible CRPS, she was going to require, in your mind, a lifetime of care. True?
Yes.
Okay. Now, reading down on this, it says on September 6, 2016, evening time, Maya had a relapse of her RSD. Maya became overstressed, extremely worried, and crying after a September 6, 2016 individual education plan meeting at Taylor Ranch School, which I strongly believe led to her RSD relapse. Do you see that?
Yes.
Okay. Did you know, and maybe you didn't, but did you know what caused this alleged relapse of RSD?
Well, it says right here,
Okay.
after the IEP meeting.
So, at least from your understanding of reading this record, there was a psychological stress on Maya that you would attribute to the relapse of RSD. Is that fair?
A stressful event
Okay.
at the IEP meeting.
According to this letter, Maya was then complaining of severe pain to her legs, 10 out of 10. True?
True.
She was complaining of severe pain to her back, 10 out of 10. True.
True.
She was complaining of severe pain to her arms, 9 out of 10. True.
True.
Severe pain to her stomach, 9 out of 10. True.
True.
Migraine pain, 10 out of 10. Correct?
Correct.
Severe weakness, nausea, and vomiting, and was unable to eat or drink fluids for 3.5 days, leading to her dehydration. True?
True.
And all of that was a couple weeks before she entered Johns Hopkins All Children's Hospital on October 6th, correct? October 7th, I apologize. Meaning,
Yes.
this was her condition. In addition, because you were telling the jury how well she was doing, I want to make sure that you understand this letter. Maya also required daily IV fluids for hydration leading up to her hospitalization at All Children's. True?
Well, this needs clarification. You can't just say true.
Well, do you have any reason to dispute what Dr. Hanna wrote to the school board saying that starting on September 6, 2016, Maya, on a letter dated September 25th, so now 3 weeks later, that Maya was requiring IV fluids for hydration? Do you have any reason to dispute this?
No, I have reason to dispute a lot of this letter because, you see, she was doing well, and then she had this IEP meeting on 9/6/16, and obviously that was a stressful meeting, and she went down. Everything, her condition got worse. Now that's a feature of CRPS.
But my point, doctor, is she never got better between this September 9th, 2016 relapse that you're claiming is a relapse of CRPS until she went to All Children's on October 7th. You recognize that, right?
No, I don't. How do you know that she didn't get better?
All right, let me show you the next record. Well, before we move on to this, the second last sentence says, as of September 15th, 2016, Maya K's RSD relapsed, and she has not returned to her usual baseline where she used to be prior. Do you see that?
When she used to be prior to 9/6/16. Okay, yeah, I do see that.
Okay, so now let me ask you about what's Joint Exhibit 1040-20. This is in evidence Dr. Hanna's records. Joint Exhibit 1040/20. And if you can zoom in to the top on the date, this is October 5th. So now, if you want to clarify whether Maya was better before she walked in the hospital, I'll represent to you, this is now 2 days before Dr. Hanna asked her to be admitted to All Children's. So let's scroll down a little bit more. Do you see on the history of present illness in capital letters, patient stated that her weekend was rough and she didn't sleep due to pain and had a great deal of nausea and vomiting. Do you see that?
Yes, I do see it.
And on the weight chart, 2 days before she went to All Children's, she was 60 pounds. That's the 5th percentile. True?
Yes.
And her height was below the 1st percentile. Do you see that?
Yes.
Do you know from your review of the records that Dr. Hanna then infused 1,250 milligrams of ketamine?
This was the day before she went to,
2 days before.
2 days before she went to All Children's.
Correct.
Yes, I know that.
Do you actually know that she underwent 5 ketamine infusions in the days leading up to going to All Children's?
Yes.
Okay. Let me ask you, Clay, if you'll turn to Joint Exhibit 1040/233. Were you aware that Dr. Hanna had his patient Maya fill out how she was feeling in her overall, what they call quality of life survey?
Okay, so I'm not just going to say yes to this.
Well, let me ask you this, and then if you need to explain, you can. You're aware of something called the American Chronic Pain Association Quality of Life Scale, correct?
Again, this is not an accepted quality of life scale.
Okay. Well,
This is by an association that doesn't mean anything.
okay. Well, let the question, you can see there's 0 through 10, where they're asking Maya, how are you feeling, with 10 being go to work, volunteer each day, normal daily activities each day, have a social life outside work, take on an active part of family life. That would be 10, normal. 0 is stay in bed all day, feel hopeless and helpless about life. Were you aware that 2 days before Maya went to All Children's, her function was 0, according to the survey? Were you aware of that?
Right, and that's expected of it. A 10-year-old child with excruciating pain everywhere is going to be, she doesn't see anything left in her life because she's in excruciating pain all the time.
Let me ask you about Joint Exhibit 1040/17. Were you aware that even after this, Maya went back to Dr. Hanna the next day for a large IV ketamine infusion? Were you aware of it?
Which date is that?
This is October 6, 2016, the day before she was admitted to All Children's. Were you aware she was up in Clearwater getting a ketamine infusion from Dr. Hanna?
Well, I do see the record, so I'm sure she did.
Okay. And in fact, at least the time of the record is 3:40 p.m. I'll represent to you she was admitted to All Children's the next morning. But according to the record, again, it says on the history and physical, patient and mother state patient is still in extreme pain. Do you see that?
Yes.
And then, Clay, I'll ask you to go to Joint Exhibit 1040/225. This is the quality of life survey filled out the day before she went to All Children's. It was 0 again, wasn't it, doctor?
That 0 is going to be there for a long, long time.
You expected this 0 to be there for months, didn't you?
Listen, if you have the world's worst excruciating pain and you're a 10-year-old kid, let alone if you had it in one leg, you would be still 0. She had it in 4 limbs. She is always going to mark that 0 at that point.
But certainly what you're telling this jury, it sounds like, is based on her condition the day before All Children's, Maya was going to be sick with crippling pain for a while, correct?
She's going to be sick with crippling pain for most of her life.
Right, including through her hospitalization at All Children's. That's what you think. Not because of what All Children's did, because that's her condition.
Right, and she did not respond to the ketamine that given to her 2 days before that, and then she had abdominal pain. And that was the reason she went to All Children's.
Because the ketamine failed, correct? The ketamine...
That episode failed.
Okay, let me next ask you about some of the things that went on in the hospital. And before I do, let me just ask you this. You use ketamine. You do not, in your practice, recommend ketamine comas, true?
I don't do ketamine coma in my practice.
Okay. You don't do hyperbaric oxygen therapy?
No, I don't.
You don't do oral ketamine?
I do sublingual ketamine, which is under the tongue. You put this ketamine under the tongue. You don't swallow the pill.
You don't drink oral ketamine with Gatorade for your patients, do you? You don't have ketamine mixed with Gatorade and have the patient drink it at home, do you?
I don't believe in oral ketamine.
Okay. Let me ask you, before we move on to what happened in the hospital, you do recognize there is authoritative literature in the field of ketamine infusion, true?
Objection.
There is a what of literature?
Hold on a second, doctor. What's the legal basis?
Improper impeachment regarding literature.
Well, I'm asking him if he can, so I'll rephrase the question. For infusion of IV ketamine for CRPS, are you aware of consensus guidelines?
Yes.
And do you consider those guidelines authoritative in your field?
I'm sorry, consider what?
Do you consider those guidelines authoritative in your field?
No.
Okay. Do you remember when I took your deposition on February 25th, 2022? I'll hand you a copy. I'm going to ask you to turn to page 37. If I may approach it.
You may.
Sure.
This is a copy of your deposition that I took.
Page 37.
Yes, page 37. And on line 15, I asked you, for the infusion of IV ketamine for CRPS, are you aware of any consensus guidelines? And your answer is yes, there is one. And I asked you, do you consider it authoritative in your field? You said yes. Well, it is authoritative.
Well, I wasn't referring to the one you're referring to. You're referring to Stephen Cohen's.
The one attached to your deposition. I asked you, was that authoritative? And we marked as Exhibit 9 to your deposition. Are you saying you no longer recognize it as authoritative?
What's attached to my deposition?
I'll hand you the article.
Huh?
We're talking about the one authored by Dr. Stephen Cohen, correct?
You're talking about that, not me.
Okay. When I showed you Stephen Cohen's article in your deposition, you told me it was authoritative per your testimony, did you not?
I don't recall seeing Stephen Cohen's, because I've never believed in those guidelines.
Okay. Well, let me ask you about some of the care that went on at All Children's. You were aware, well, let me just ask you about, you reviewed the records from All Children's, true?
Yeah, 7,000 pages.
Okay. Let me ask you about Joint Exhibit 1001-2718. At the bottom where it says result comments R46, the second paragraph, did you review this record? Patient also stated in the room with me that she hasn't eaten in 5 days. I asked her if she doesn't have an appetite, and she said she can't eat because she's not allowed. Did you review that record?
Listen, there were 7,000 pages, so I can't tell you whether I reviewed it or not. But I agree that if you're showing it to me and you tell me this is from them, yes.
Let me ask you about Joint Exhibit 1001-3746.
Objection, Your Honor. Improper impeachment. He's not reading the second sentence right there that explains it.
Overruled. You can continue.
On Joint Exhibit 1001-3746, at the bottom, were you aware in reviewing the records that Mrs. Kowalski refused to have her child evaluated by psychiatry on admission? Were you aware of it?
Oh, yes, and I'm not surprised.
Okay. Were you also?
That's very appropriate.
Were you that you? So what you're telling this jury is you don't believe that Maya should have ever been assessed by a psychologist. True?
True, absolutely.
Okay, so let me ask you about her time in the hospital. Were you aware in reviewing the records that All Children's Hospital tried to transfer Maya to a comprehensive program for CRPS, but the parents refused?
Objection. No, there's no facts and evidence on any of that.
Okay, let me direct you to Joint Exhibit 1001-1765. Under projected discharge planning needs about halfway down, placement, and I'll represent to you this is November 10th, inpatient rehabilitation care, court order pending, parents declining to sign consent at this time. And then under provision of care, it says mother continues to deny consent for inpatient treatment at Nemours. Were you aware of that?
What's the question?
My question is, you've been critical of the care Maya received at All Children's. All Children's was trying to transfer her to a comprehensive center for...
Objection, this is
He asked me
not in
to...
evidence. None of these documents are in evidence.
This is the joint exhibit from All
Time
Children's.
out. Gentlemen, if you could approach. The question is sustained, but you may continue, Mr. Shapiro.
Thank you, Your Honor. Doctor, were you aware during Maya's hospitalization that the parents declined to have her transferred to another hospital for care?
But
Were you aware of it?
well, yes, according to what you're showing me on the document, yes. But I need to elaborate why they refused.
Okay. Well, you're welcome to when Mr. Anderson asks you questions.
Actually, you can answer.
Okay, go ahead.
Finish the answer now.
Yeah.
Go ahead.
Well, because the idea of treating CRPS is first you've got to control the pain. You can't have a patient with severe burning pain in 4 limbs and you put them into an inpatient rehab center and start making them exercise. So ACH was not doing anything to help her pain. And so they need to control her pain, and then they would have transferred her to any other place they could. She was doing rehab anyway. She was even doing rehab at ACH.
Are you telling this jury that in your review of all the All Children's records, they never offered Maya anything for pain?
Not enough.
They offered Maya pain medication during her hospitalization. You know that.
But they didn't control the pain.
You are aware that, or are you aware whether there were attempts to transfer her for outpatient therapy? Are you aware?
Same objection.
Sorry, could you rephrase that question?
Are you aware of whether All Children's attempted to transfer or discharge Maya earlier in her hospitalization for outpatient therapy?
Well, I mean, you're not getting my point. My point is that All Children's did not control her pain. And now they're trying to pass her off to an inpatient rehab or an outpatient rehab or something like that. That's what they're doing. And the parents didn't want that. The parents wanted her pain controlled, and they would have done the rehab happily by themselves. They were doing it at Dr. Hannah's place.
And we talked about Dr. Hannah's records and their success rate, but let me ask you about your evaluation of Maya. your report. By the way, the recommendations you made in your, well, let me just back up. I apologize, doctor. You've seen Maya once for a forensic evaluation in January of 2017, correct?
Yes.
You have not evaluated her since, true?
No.
Okay. You sat with her for 5 hours and 22 minutes?
That's correct.
What pain medication did you give her for your evaluation?
No, it's just an evaluation, not a treatment.
Okay. She was able to tolerate your evaluation without any pain medication.
She wasn't. She was in severe pain.
She sat with you for 5 hours and 22 minutes, true?
She lay down. She didn't sit.
Let me ask you about some of your statements or plans of care. And actually, let me, I think this is Joint Exhibit 2005-1. Clay, if you don't mind putting it up on the screen, please. Well, I may have the wrong exhibit. It's there we go. I think this is what Mr. Anderson walked you through. True?
Yes, he did.
Okay. The way, and it's a technicality, but I thought it was important to point out, so let me just ask you. This report that you have was actually a letter back to her primary care pediatrician, Dr. Wassenaar, true?
Yes.
Did you ever speak with Dr. Wassenaar?
No.
Let me ask you about some of the recommendations in your report. By the way, at this point, Maya hadn't walked in almost 2 years, true?
I don't remember that.
Okay.
For how long she hadn't walked.
I'm not trying to trap you, I promise. The testimony that the jury's heard is generally that after about July 4th, 2015, she was in a wheelchair from that point going forward. And if I got that wrong, I'm sure someone's going to jump up and tell me. But all that being said, so now we're 2015, 2016, so about a year and a half, she has not been out of her wheelchair walking, okay?
Okay.
Would the lack of walking secondary to what you believe is CRPS cause her legs to be atrophied?
Yes.
Let me ask you about some of the recommendations that you were talking about with Mr. Anderson that begin, I think, on page 18. It could be 19. That's it. All of these recommendations are because Maya has CRPS, true?
No.
Well, I guess that's fair. Some of these are because you think she may have had Ehlers-Danlos syndrome, true?
Right.
That's a genetic disease.
Yes.
Did you test for it?
I did a clinical. There's no blood test for it. It's a clinical test.
Okay. Do you know if Dr. Wassenaar ever followed up on your letter to him recommending treatment for Ehlers-Danlos syndrome?
My job was very clear. The question I was asked was, does she have CRPS or not? And that was my job. My job was, I wasn't a treating physician.
I understand. You were serving as a forensic expert on this issue, true?
True.
Okay. But you did, in your evaluation of Maya, believe she may have had a genetic cause for some of her problems, true?
Could be.
And you also thought that she may have had a neurologic cause in the form of a tethered cord unrelated to CRPS.
I wasn't sure. I needed her to see a neurosurgeon to decide that.
Do you know if Dr. Wassenaar ever followed up with a neurosurgeon?
I don't know.
You also, in your report, if you go down a little bit on the same page, talked about bilateral thoracic outlet syndrome. Do you know if any follow-up was ever done for Maya regarding that?
We've already established that this was my one and only contact with Maya, and it is a forensic exam, so I'm not the treating physician. I don't follow up.
Okay. Then I promise you I won't belabor the question. the answer to any question I ask you of, do you know if Dr. Wassenauer ever followed up with this, any of this, the answer would be you don't know.
No, I don't know.
And in terms of her complex regional pain syndrome number 11, it says minimize surgical trauma. At the bottom, 11A. Minimize surgical trauma, including needle sticks. Okay. It was your belief at that time that Maya's CRPS was so bad that for the going forward, she wouldn't be able to tolerate needle sticks. Is that true?
No, that's not what the recommendation means.
Okay, so and let me try to clarify. I appreciate that. In terms of what you're telling this jury, you don't know in the future whether Maya is going to have this problem because you haven't evaluated her. True?
We know she has CRPS. So this rule applies to her for the rest of her life. So a person can have CRPS in their left leg and they still are at risk if they get a needle stick in their right arm.
Piercings. She'd be at risk if she got piercings.
That is a risk.
Okay. Do you know if Maya ever got piercings?
No, I don't know.
Do you know if she got piercings, whether she had any pain from them?
I don't know.
Okay. Do you know if she's had any subsequent surgeries where she's had any problems as a result of surgery, or you don't know?
So that's not how the human body works. So if you have CRPS and you get a piercing or you get a surgery, the chance of your CRPS getting worse or spreading is high, but doesn't mean that it will get high or it will spread.
So what you're telling this jury, you're not saying that these things on her list are more likely than not to happen. You're just saying that these things on your list are things that somebody, for example, with CRPS might encounter. Is that fair?
It's a,
Vague. Overruled 14 of them.
it's a standard recommendation for any patient with CRPS.
Got it. The recommendations on here are standard for anyone who has this diagnosis, true?
Recommendation 11A.
Okay. The just a couple more questions, Bob. Well, let me ask you a little bit about, you don't know how, I mean, I know she's in the courtroom, but you don't know physically how Maya's doing today, true?
No.
Okay. But you can tell physically she's doing better today than she was when she was brought into All Children's, true?
Well, first I didn't see her when she went to All Children's, and today all I've done is see her from a distance. That doesn't mean that she can't be in severe excruciating pain.
Has anybody, have you, in your time working on this case and working with Mr. Anderson, did you ever ask Mr. Anderson, how is Maya doing today?
No.
And when she saw you, she was in a wheelchair, right?
Yes.
And now she's walking today.
Yes.
One moment, please. I don't have anything else further at this time, Your Honor.
Maybe we put one exhibit on.
Sure.
the jury, my conference is going to take a few more minutes, so what I'm going to do is I'm going to send you for a short break. Let's try to keep it 5 minutes or so. Do not discuss this case amongst yourselves. Do not do any investigation and receive no information. Let's try to keep it to 5, maybe 10 minutes, okay?
All right, for the next thing.
Okay, the jury is out of our presence. Everyone please be seated. Mr. Shapiro, Mr. Anderson, does Dr. Chopra need to step outside, or can he sit here while you do what you need to do?
It's up to Dr. Chopra. If he wants a break, I have no objection.
Do you want a couple-minute break, sir?
Yeah.
Okay, why don't you come back in 5 minutes? Just remember,
Sure.
you can't talk to anybody about your testimony. Just so the clerk's aware, we're now talking about Exhibit 3035 and perhaps certain pages, including 0024. And we're going to wait on Mr. Shapiro to give us additional pages to look at.
Take your own.
Do you want me to sit here, or do you want me to come back in 5 minutes?
You're welcome to come back in 5 minutes, sir.
Okay, I'll be back in 5 minutes.
just looking, they just handed me the documents they want to put in.
Okay, go ahead and review and let me know if there is any objection.
This is still common.
Right. I mean, we don't need you at sidebar at this point. What are the, is there an agreement or are there objections?
There are objections, not to the complete document, but there's objections to the introduction of explanations of court hearings, court strategy, and the DCF.
Time out. Just tell me specifically what pages we're talking about. In Exhibit 3035,
3035-12 would be one of the ones that if we're going to go into this with this witness, I would want recross on.
12, and then what are the others?
3035-22 and 3035-23.
Okay, so can someone put up 12, 3035-12? And what is the objection, Mr. Anderson?
I think these are together, but if you look down under 3 p.m., Kathy stated parents are still in court reviewing patient's case with judge, and they do not anticipate meeting will conclude before 5 p.m. And my concern with this, Your Honor, is that I don't know what this witness is going to say once they open the door to the DCF matter, because I have not briefed him or prepped him, so he knows the rules. And so when we get into the DCF stuff, I think it's going to be the Wild Wild West. And this is loaded with it, including, if you see the next page, Judge would like appointment to be scheduled sometime tomorrow morning. We're going to be starting to try the DCF case too. So if you look at the next page, it's more clear.
Page 22.
Yes. So
This part.
yeah, CPS has been contacted and is going to come to All Children's this afternoon to begin their investigation. I thought that what's the date of that? I thought that was out of evidence in terms of being used for cross-examination, but
Well, here's where I'm at right now, Mr. Anderson. Again, this is all predicated on what you're going to do with this witness. If I already told you, if you wanted to go into 3035-0024 with this witness, I'm going to let you do it. But so far, and these other documents will probably come in so far. I mean, and yeah, there's some things in here that I'd rather not be, but the Nemours issue probably is going to have to get explained somehow to the jury anyway.
well, it's fairly complex. And again, what happens if the witness who doesn't hear anything, doesn't know anything, starts telling what he knows about the DCF investigation, how unfair it was, all of the different things that we're alleging. I don't know what his knowledge is on that, Judge. And so it's very likely, I think, that we're going to get a lot more. This particular point here that they're trying to raise, I think, can be covered in other ways. But the main thrust of this is that they're getting DCF involved. It's the 9th. It's 2 days after they came in.
Well, again, this is predicated on what you're going to do. And, I'm not going to tell you how to try your case. It sounds like you don't need this witness to talk about the issue that you want to talk about, but hey, if you feel like you want this witness to make those comments, then I'm going to let you address the 0024 document. But on cross-examination, then I'm going to let them address at least 12 and 22. I haven't looked at 23 yet. So if you don't go there, then we don't need to make any rulings. If you do, then we will. So it's up to you.
My biggest concern is I was hoping to have a couple extra hours this afternoon, which are rapidly evaporating. If they're just going to